Sherry. That's Sherry, right? She's the one that has been phone calling you guys and emailing you and keeping everybody in good communication to answer any questions, where we're located, mailed you your packets and all of that good stuff. I thought I'd take a quick minute and introduce the rest of the staff that's here today. I have Scott, he's our clinic director here, he's one of our PTs. Kai is one of our physical therapists here, and Amy is a physical therapist assistant. So Scott's going to be up here and help me take down some information as we get to know all of you guys a little bit better. I'm Michelle Sierra. You've seen my face. Maybe you don't recognize me because those videos were done during COVID time and we couldn't go get our hair done, so I'm a little brighter today. We've done everything we can to try to keep you guys spaced for COVID purposes. Once we feel like everybody's back and we're have enough good spacing and whatnot, I'm going to go ahead and stay 6 feet away from you guys so that I can take my mask off. Because what I found is you can't do this with a mask on. We're reading lips more than people. I can't communicate well. So we'll do that, and we'll avoid the handshaking and that sort of thing, although, you know, miss those days. But I'd like to get to know you a little better. Kai and Amy are, hey there, gonna take a seat in the back, and they will be in the back when the presentation is over, so we're anticipating being here for about an hour. Hopefully answer your questions, give you a lot of good information, and then hear some of your questions. So they'll be in the back in case in the end, 10 minutes or so question and answer time, okay? And so Scott's gonna help me out. All right, so I think we're right on time. This is Laura, she's one of our other PTs, and she's gonna be here to help with question and answers at the end as well. So I told Kai and Amy if they wanna have a seat in the back, that's probably better for you guys. All right, so our main agenda for today is to answer all of your questions. How many of you guys finished the worksheet before you got here because you're overachievers? All right, yay, A+ student. Now at the end, let's get together and see which ones you got right.
Yeah.
I hope you didn't spend too much time researching or having to look up any of those answers. We're going to cover a lot of that today, and then I'd like to give you a little bit more specific patient information and answer any of your questions. Before we get too far, you know who we are. I want to know a little bit more about you. So Scott's going to take down some information over here, and who wants to start with just an introduction of, why don't you tell us your name?
My name is Dennis.
Dennis.
Yes,
Okay, awesome.
Yes, ma'am.
And what brings you here?
Well,
Left or right
just
shoulder?
like everybody else.
Shoulder problems?
Yeah. I'm right at 68 years old and having lots of shoulder problems, both of them for the past 10 or more years. You know, used my body a lot through the years working.
Was it just a gradual onset of things, or did something
I
happen?
think it was gradual, but just got worse and worse.
Uh-huh.
And now, if I do anything outside, it's hard for me. It hurts a lot, and I can't really sleep well. It wakes me up at night on both shoulders. Can't sleep on the left side or the right side. If I put pressure on it.
All right.
Oh, I guess age too, you know.
So I'm going to write down over here some of the key things that you said are limiting. You said sleep. I heard that one loud and
Yep.
clear.
Yes, ma'am.
You said working, like lifting or overhead or
Shoulder work, post hold,
Yard work.
and pulling.
all right, using those arms.
Pounding.
Got it. Thank you. Thank
But
you.
I know this didn't happen to me overnight,
Right.
and I'm trying to avoid any more surgery on my body.
And more surgery. Now, any history of shoulder surgeries?
For me,
Yeah.
shoulder, no.
Okay, good. All right.
No shoulder.
Good.
Not yet.
My name is Glenn.
Glenn,
Um,
nice to meet you.
it's my right shoulder right now.
Okay.
My left shoulder. Had surgery on both the shoulders already.
Okay. And still having trouble?
Yeah.
And you kind of wonder,
Well, it's been a couple of years.
Okay.
Quite a few years actually.
gotcha.
And
What did you have done?
the left was impingement,
Mm-hmm.
and the right was rotator cuff and loose. You know, just very loose. There's a lot of causal damage to this. And
Traumatic? Did anything happen?
no, it's a lot of it had to do with baseball in my younger years.
Baseball, sports. I think I
So-
see a young guy in the back that may pick on you for a minute. Aren't you here something about sports too? Yeah, Sherry was giving me some of the information. I haven't put faces with names yet. So sports or active use, so yard work, just really being active.
Right. So, but I mean, and like I said, I had surgery done on both on the scopes and,
Just not quite where you want it, and you see it's changing over time.
yeah, and like I was told from the beginning when it all started, that if you maintain therapy or exercise and keep the muscle strong, you should,
Good point.
longevity.
Sure.
So, and of course I've been lacking that.
Okay, so you're kind of looking for some answers of what could I do now to help this get better, to avoid any additional surgeries or.
Yeah, I got my stretch bands and
Good.
I'll do those and that helps temporarily.
Good to know.
So, but
Good to know.
besides going back under the knife,
What else can we do? Your current plan is not really solving the issue, and we are trying to avoid bigger solutions down the road. Gotcha. What brings you here? What's your name?
PJ.
PJ, okay. And left or right or?
Both, actually.
Both?
It's been a hurry for like about 6 years.
Did anything happen? Any trauma or injury?
Not really.
Okay.
So like 6 years ago, I'm in the military, and so I went through the training and all that, and
Should I write rough and tough stuff? Military? Yes.
So when I came back from that, and it was hurting for a while, and I went through the physical therapy, and it helped. And but I'm a fairly active person. I like to work out and all that. So right now,
Exercise.
it doesn't hurt when I'm not doing anything. But like if I try to do anything little intense, and it hurts. And so it mostly like it's like overhead motion. Anything I'm pushing, it takes me like almost like a week.
What about like bench press,
Yes.
overhead press? So you
Yeah.
can't.
Anything like overhead press or bench press, it hurts.
Right, good. Would you like to share what's
Yeah.
going on with you?
My name is Angie Hatfield, or Angelia, but everybody calls me Angie. It's my right shoulder,
Okay.
and it's only been bothering me, I guess, for the last maybe 6 months. But I've been also taking care of my father-in-law's 95, and it's, helping him stand up,
Yeah.
pulling on him, and
So
so,
it's all that extra work on that right side.
and it just burns and it's inflamed, and
So you have treatment for it yet at all?
no,
Okay.
no,
No PT, no real,
no,
just kind of here to
stayed
gather some
away from them.
information. Okay.
It really started bothering me around April, bad. And a lot of times I can alternate heat and ice and feel better. But again, it's temporary. And I realized that I had a major problem. I tried to go swimming, and that motion to go overhead, it wasn't happening. So I ended up dog pedaling back to the side. I know.
Avoid that overhead motion. Okay, good. Well, we have some thoughts on some of that stuff. I'm hearing a lot of interesting stories and repetitive things. Who else wants to tell me a little bit about what's going on with their shoulder? Go ahead.
My name's Walt. I'm a carpenter and painter, and this shoulder's hurt for a while, anything overhead, and I fell and hurt this one about 2 months ago, and now I guess maybe I'm compensating. This one is extreme pain, can't sleep, the seat belt kills it.
Yeah. Seatbelt. What about, is it interfering with your work as a carpenter? You do a lot of overhead.
It's not
Alright.
pleasant.
Can you join us for our rotator cuff workshop? Awesome. Did you check in at the front yet, or you parked and came in back? Do me a favor. There's some paperwork and things up front. Will you show her, Scott? We do have a back entrance, and parking is right there, so everybody, it's fine. And Kathy Ann perused through here. She's one of our other PTs. So we have a crew back there willing to help out at the end. So carpentry work. Some overhead stuff. Some.
There's spots where it's had no strength.
Any treatment so far? Yeah. Do you want to share with us a little bit?
Sure. My name is Giselle, and I can't pin it down to when this all started.
It's gradual.
Yeah, but around October, my left non-dominant shoulder started bothering me. And I'm not only having trouble with overhead and like reaching behind my back, but also like lateral raising arm, especially if I have even a light object.
talk about that a little bit. Why is that? Have you put any thoughts to that, or what's going on there?
I can't figure out what I could have done to initiate that.
What do you do for work? What do you do for exercise? What do you do kind of during the day?
Work, I don't do any heavy lifting. I am a left side sleeper.
Okay.
And exercise, I'm pretty right focused, so.
Okay, good to know. So like there's no trauma, there's no heavy lifting, it's not heavy exercise, I don't swim. Why me? Right? I'm fairly young. Some of these guys talk to, well, I'm getting older and maybe some age-related change. So we're gonna kind of keep that in mind. Anybody else want to share?
Yeah, I'm Roseanne Simons, and I'm real active. I ride bikes and stuff, and I do work out, but I had a dislocated AC, or separated AC.
How'd you do that?
Somebody ran into me on my bicycle,
Okay,
with another bicycle.
that'll do it. Dramatic stuff.
So anyway, so this, I never got it repaired. I just left it.
Yeah.
And that's been about a year ago. So this one, I went to physical therapy for it and everything, and it kind of helps, but it's not starting to hurt. But actually, this one, my good shoulder is hurting a whole bunch.
Do you think it's because you've been more active on the right side, maybe making up for the left side?
Yeah, I don't know. And then to reach, to swipe the parking card, this hand is like, I have to turn
Circle
the whole
motion,
body. Yeah.
turning your whole, so you've kind of adapted what
Yeah,
you're doing.
I know, lately I haven't been able to sleep, it's been going on for about 3 months. I've been going to physical therapy, that helps, but, it's still pretty painful, especially reaching high
Yeah.
with either hand, and then I try to go do weights again. Like all the, the butterflies, I can't.
And so it's kind of contradictory. Here we are talking about 3 simple exercises, do your exercises, do your thing, but then you sometimes get frustrated because you try to go exercise and it makes it
It
worse.
hurts.
Or to your point. And so
Yeah.
you kind of get lost in the shuffle, whether it's like searching what's my quick fix on YouTube, or if I would have sent y'all on YouTube top 3 exercises and you try them and you're like, oh, that's only making it worse. So we're going to talk about that a little bit too.
Yeah, I had a 1 pound weight and I was doing these, like laying on the
Yeah.
side. I'm like, really?
I know.
It was difficult
I
getting
gotcha.
this.
It's 1 pound. You're like, why?
Yeah.
Well, thank you. Thank you for sharing. So I heard some common threads here. I heard a lot of people, if we took hash marks, sleeping, overhead, certain ways I reach or move my arm, work, anything we missed, anything we didn't talk about that aggravates you. Yes, ma'am?
Oh, that aggravates you?
Yeah.
I sometimes wake, I know I have a torn rotator cuff.
Okay. Now, did they tell you, is it a partial tear? Is it a full thickness tear?
I got an MRI a year and a half ago, and my doctor wanted me to do surgery immediately, and I was like, no, I'm waiting on this, because I read up, and I saw that a lot of times rotator cuff injuries can heal on their own, and so I just gave it time. I'm a yoga instructor, and I just try to do very gentle mobility, moves.
Time and mobility was kind of
Yes,
your...
yeah, and
and-
try to reduce inflammation,
Good.
doing some muscular massage to release trauma. But what's happening with me is we just redid our floors, and the very last day I lifted my bed, and ever since then it's my shoulder dislocates, and I
Wow.
wake up with it dislocated.
Interesting.
It's awful.
Tell me your name.
Faith?
Faith. All right. Vanna, you are not doing your job well, Vanna. Well, you put, it's your left shoulder?
It's my left shoulder, but I think compensating, I'm noticing pain in the right
Okay.
shoulder.
And so if I hear you correctly, you kind of knew some things to do, like I'm gonna take it gentle, I'm gonna try to avoid surgery, I know I've got a tear there, I'm calming down the inflammation, I'm working my mobility. It got better until you had to actually use it, and it was like, oh,
Yeah, and then it's like I'm back to square one.
it erupted again, and now you've got to, okay,
Right.
fair enough. No PT, no injections,
Not yet, no. I would rather do less invasive to,
but an MRI that did show a tear.
yes.
Okay, and we'll talk about that.
Yeah.
Okay, well, I want to keep it short so that we've got a nice sized group here. Thank you for those of you that were willing to share some of your stories. I think we see common threads for sure. And hi, welcome. Restrooms are there. Do we have a chair? Okay, so let's move on to giving you some answers here. And I'd like for you to fill them in, and then we'll kind of talk on it. So what is the rotator cuff? So question number 1. The rotator cuff is a group of 4 muscles. And joints that move is your second blank there, the shoulder. So 4 muscles that move the shoulder. So here is, I'm gonna blame this art on Scott, my Van White friend here. Oh, don't be that patient, okay? You do not want to have a totally dislocated clavicle, sorry. This model's been around for a while, so we're gonna fix that. Okay, so this is for drawing purpose. This is as if you're looking through my chest. I've taken the ribs off, I've dissected my body in half, and you're looking through here, and you're looking at basically the front side of my shoulder blade. That's what you're looking at here. It's one really big muscle here, the subscapularis. It actually has attachments onto your rib, and it's one of those 4 rotator cuff muscles, okay? Let's look at it from the other angle, the back of my shoulder, right? So now we're looking at this shoulder like this, and you have a supraspinatus, it's on top here, an infraspinatus, it's on the bottom here, and this is the spine, so on top and below of the spine. 2 of your other rotator cuff muscles, and then you have a teres muscle kind of right under that piece there. Those are your 4 muscles that are your rotator cuff. They're called rotator, and you guys are giving a lot of rotational type movements because one of their jobs is to rotate the humerus, don't be that patient, which is the long arm, right? The long arm here. You also have here the other parts, your clavicle, which everybody can feel right here. It's also your collarbone. So kind of a lot of moving parts here. Collarbone, scapula, 4 muscles, your humerus or arm bone, and it makes kind of a complex scenario. When you guys heard of rotator cuff, did everybody know it was a group of a couple of different muscles, or did we just think the rotator cuff is one thing? Many times new patients come in and they think my rotator cuff is like this one thing. Or I have a tear in my rotator cuff. Well, I'd like to know which of the 4 muscles.
Right.
And I'd like to know, is it a partial thickness tear? How big is it? Da, 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 da. I can find some of that out with diagnostic imaging, but it's really not gonna alter my treatment plan, okay? And so we'll kind of put some of those pieces together. All right, so back to our answers. The shoulder, we're on B now, is a blank and blank joint. It's a ball and socket joint. And I use this analogy, and I'm keeping these little props here. And I wish for 20 years, I've been a 25 years I've been a PT now, and I always say it's like a baseball and a teacup saucer. So, the teacup saucer is the actual socket. So there's not a lot of support here for your ball, which is on the long bone here, to sit on. What is holding the ball to the socket here? Certainly not your bones. It's the rotator cuff. The rotator cuff creates a suction and it pulls that ball into the socket and it provides a lot of stability. It's not just a rotator, it's a stabilizer. And we're going to go into later, for those of you that mentioned impingement and some different things, you actually had surgery on your impingement. We're going to talk about what are some of the muscular imbalances or other joint problems that can actually take up some of that space and lend to impingement where the ball moves up and creates for a lack of space for movement. And then you get pinching on that rotator cuff. So ball and socket, everybody's got that takeaway?
I have a question.
Yes.
Like for surgery, how would they correct that?
Good question. So there's a number of things. Do you remember what they did on your surgery for impingement? Did they call it a subacromial decompression? Somebody heard of that?
Yeah.
SAD?
Yeah.
It makes you sad. No. It's a subacromial decompression. So let's talk about that. What's the acromion? I talked about that a little bit on one of the videos. I threw it out there lightly and said, you guys don't have to remember that. So let's look at this little piece here. The acromion, if I was able to fix my shoulder anatomically correct, would sit like this. So your collarbone comes here and you have this, everybody can feel it, you've got kind of a bony, knobby piece. That's the acromion. Off the back part of the spine of the scapula is what, so here's the clavicle and the acromion, the spine of the scapula comes around and acromion on top. It creates a little bony junction, but do you see that this supraspinatus runs right through this tunnel, the bony tunnel, and what happens over time, here's that ball we were talking about, and the socket, see this is why this thing comes apart, is deep in there. What happens over time, if your muscles are not properly imbalanced, and this is more than just these 4 rotator cuff. We're talking ribs, how they come into play, big lat muscles, how they come into play, your pectorals, how they come into play, your ribs, how they come into play. It's a lot more than just the rotator cuff, but impingement happens because the ball starts to come up and impinges there. Over time, you start to get some spurs. Have any of you guys heard of spurs and bone spurs and some of the osteoarthritic change? Oh, you have a spur. It's like, oh my gosh, well, we're gonna have to remove it. They typically don't do surgery on a grade 1 or 2 spur because it's so minor. What causes that spur? Do you know what causes that spur?
Calcifications, isn't
This
it?
bone hitting up there, it starts as inflammation. Your warning sign is what some of you guys have described right now. It's inflammation. Oh, it's a little bursitis. It's a little tendonitis. I pinched something. Oh, I'm getting a pain cascade. Your body is giving you a pain cascade to say, hey, stop doing that, whatever it is you were doing, because it's causing this to happen. But over time, your body responds in a different way. That repetitive stress over time can create for those small tears in the rotator cuff. And the tears will start growing like tendons will grow. You ever see somebody has a really big, thick tendon or a really big tendon on your knee? And that takes up that space. And the spurs here begin to come down and take up that space. And now you don't get very far. So they will go in and shave under that bone.
Good.
Many times, that's a great solution. If you don't create the biomechanical faults of why was it budding in the first place, it's coming back. And I've had a number of patients, after they recover and they've gotten through the healing or whatnot, well, I did the surgery, why am I still having that? And it's because all of the other muscles are not working properly and you still have this budding up in there. If you didn't have the surgery, you just continue to ignore it over time, and if scar tissue and enough tissue damage occurs, you'll end up with a small thickness tear. That doesn't need surgical repair. It needs help to correct the mechanics before it turns into a bigger tear. Does that make sense? All right. Don't get me talking because I could talk a lot. And I don't want to talk your ears off. I want to get through it all. So, to see, these 4 areas work together during shoulder movement. So I've kind of thrown some hints out there. The first one is your neck. So your neck, there are a number of muscles that have a shared attachment to your neck or your cervical spine, and then also to your shoulder, to your collarbone, to the various shared structures. The next one is your collarbone. We talked a lot about that, right? The collarbone. That's where the acromion is off here. Did you know that your collarbone, and it's funny because Kai and I had a patient just this week we were working together on, and she was a lady, she had a fall, didn't she? She had had a traumatic,
It was a box fell on her.
a box fell on her, right? She had seen the doctor and he didn't want to do anything, he wanted her to have PT, but she was so, imagine a botch, and it was like a 30-pound box hit her right here. So we were pressing on her clavicle and her collarbone, and I said, they were doing some mobilizations to the AC joint out here to make sure that the collarbone was rotating properly. And I said, have you noticed right here where the collarbone comes and meets with the chest bone? Is that moving properly? And so we took a minute and we did some mobilizations, and sure enough, we were able to get some things moving better. And I want, just for demonstration purposes, you guys find your own bone here. Put your fingers on it, just kind of feel on it. And maybe on the non-painful side if you have a non-painful side. And then I want you to raise your arm up and feel how that bone rotates back under your fingers. Tell me, anybody's aware of that now that I've pointed that out? Can you imagine if you did not get that rotation back, if it was stuck down, maybe because the muscles were inflamed holding it stuck down from the box injury, maybe from overuse of your pecs because you've been doing too many push-ups in your military training. Thank you for service, by the way. Maybe it's stuck down and not moving well. Well, you're gonna get so far, and if that collarbone does not rotate back, your shoulder's not going. That's not gonna show up on an MRI, is it? How many times do patients come here and they're like, I know it's torn, I know it's torn, MRI didn't find it, but I know it's torn. Okay, let's look at everything else, because there are other parts that have to move well together. lumbar spine, it's so big, but it's good for demonstration purposes. We have patients sometimes that come in and by the nature of how their symptoms are going down the arm, we know straight away, I better check your neck. There are a series of nerves that come out in the neck, and those nerves come together and they form the brachial plexus, and that's the nerve bundle that innervates your rotator cuff muscles. If you've got something going on up in the neck that's compressing those nerves and shutting down some of the electric impulse, you might have weakness, random weakness that you don't really understand, and you think it's your rotator cuff, it might be coming from your neck. Would be good to know that, right? So we're trained in how to identify some of those outside areas as being problematic when you're having shoulder and rotator cuff pain. The third answer is shoulder blade, right? Your shoulder blade also, Scott, come over here. So, if this is Scott's shoulder blade, if we isolate this out, we like to be very black and white, let's just focus on the shoulder. But how many muscles attach on this part of the shoulder blade and have shared attachments over to the spine? A lot. What if he's got some spasm up here because he's been sitting at the desk doing paperwork for too long? And these postural muscles or stabilizers are off, or maybe it's some work related, some tool he's doing or something that I don't know. If I don't assess here, and this shoulder blade cannot glide, good job, Scott. Imagine this has to, we know how, there is a mathematical rhythm of how this moves. So, if his shoulder blade is not allowed to glide like this because of spasm going on over here, he's never gonna get overhead. And that's what creates some of that boom, 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 the humeral head causing some of that inflammation. If you don't have somebody that understands how all the parts work together and are willing to kind of look at all the underlying causes, you're gonna miss something. And those things are not gonna show up on X-ray and MRI. They just don't. All right, and then the last one is your rib cage. Your rib cage. So a lot of these muscles have shared attachments onto the ribs, and your ribs have to be able to glide upward and downward and move to allow for normal motion. All right, a couple of success stories, and I'm gonna make these a little bit quick. We talked about our lady there, and after we got that set in place and we added just a little bit of stability tape and we started working some of that inflammation, how's she doing?
She's doing a lot better. She came in today, she's even said, hey, I don't really have a pain anymore. Every now and then it kind of catches and she knows what to do, because she did have some postural issues as well, which we addressed. So addressing her posture, once we figured out what was the SC joint, which is firm, once we figured everything out, we strengthened her, she's been doing so much better.
And because of her posture, it would want to keep moving that joint out of place. So it's one thing for us to be like, boom, 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 let me fix this. And you think it's going to be a quick fix. But what is it that you're doing outside of here that's making it go back that way? What kind of muscle imbalances happened as a result of the way she was moving or what was going on? And to somebody's point, forgive me, exercise. How do we know which ones to do? It's not as simple as just go to the gym and exercise. When we're talking about that ball in a socket, it's kind of like a nasty game of tug-of-war. I showed you where some of the muscles live, you know, in the shoulder blade to the rib cage, to the spinal column. If you've got two that are too tight pulling the ball this way, and the two on this side are too loose, how do you guys know which ones to stretch and which ones to strengthen? You're not gonna be able to figure that one out on your own, and it truly takes an individualized evaluation to be able to help you through that process. Does that make sense? And it's an ever-changing fluid state. As I loosen up some of those muscles and now that's moving, he's not moved in that direction for quite some time, and he might be more prone to impingement if I'm not there teaching that muscle how to do its job again. I had, on one of our last workshops, I did a phone call, and this one it stood out to me, and I just thought I'd share it. Just like I was asking you guys, hey, what's going on? Tell me a little bit more about it. She said, you know, it's the darndest thing. Ever since I had to go in and have some stents placed for my heart in January, it's just kind of gradually come on. My heart procedure's fine, everything's fine, I've been checked out, they don't really know what's going on. And all I could think about, her ribs. How were her ribs moving? What happened that she was maybe guarded after the procedure or just trying to protect herself or moving differently? And if she didn't have that rib mobility, how is that now affecting her shoulder? This was a phone call, so I really wanted to get her in here to see was that piece of the puzzle, and sure enough, that was probably her underlying cause of her whole shoulder problem. It's not going to show up on an MRI or an X-ray. And if I didn't know how the ribs and the shoulder and the scapula and all these parts move together, I would have missed it if I wasn't a PT that was trained in how to know all those pieces go together. It's making sense? Let's see. You told me last time a story about somebody who had come in and was so sure, because their pain was pretty severe, and it was an impingement case. Doctor wanted to do surgery, and the patient was like, ugh, is there anything else we can do first? Do you want to tell them a little bit about
Sure.
how that went?
So he came in with, with your typical forward posture, rounded shoulders. So when we do our assessment, the first thing we look at is your scapular position. So looking from the back side of that shoulder.
Scapula is your shoulder blade.
So, can I use you for a second? So from that back side here, they should sit nice and even. Okay, there should be no popping out. So his shoulder blades are actually way up here.
Mm.
So he rounds really big. I was able to fit almost 2 knuckles from his ribs to the bottom angle of that shoulder blade. So the first thing we worked on was a ton of posture, strengthening up those muscles that lie from here to the spinal, to your spine, trying to open up his posture there, and it took all of his pain away through here. So we did a lot of soft tissue work through his pectoral muscles, through his bicep, opened him up in his chest, strengthened him up in the back, and then he was able to go back to doing his woodworking, going back to doing his lawn mowing with pain, no pain, no blood, no surgery.
Did you hear Scott say, open it up, open it up? You remember that tunnel that we're talking about? There are a number of ways we can create space in there through the musculoskeletal system, whether through the appropriate hands-on treatment, a lot of hands-on, whether it's soft tissue work, like massaging, mobilizing, trigger point work, or whether it's joint mobilization. I might be on the ribs, I might be on the spine, he might be on the scapula. It's a lot of hands-on, and then it's supplementing that with teaching you guys, okay, here's what not to do in the short term. Here are the proper exercises that are going to reinforce that based on what your individual findings are, and that's truly where the magic starts to happen, okay? Thank you. So, there is another quick thing we can talk about is MRIs. We've talked about MRIs. How many in the room has already had an MRI? 1, 2, 3, 4.
Just on your shoulder you're talking about?
Yeah, more like for shoulder. All right, so there's an interesting statistic. So I've thrown out there a little bit of maybe what MRIs can't help us do. What we know they can do is they're gonna pick up partial tears or full thickness tears. And MRI is, what's the difference between X-ray? X-ray is looking at bones and bony structures. Good, we can rule out things like bone tumors, fractures, especially if you had a traumatic event or something like that. We can rule out some of those big red flags. I don't want to be mobilizing a fracture or a bone tumor. Like, that's not my place. There's some red flags though, right? To those sorts of things. Typically, a fracture, you've had trauma, it's big and swollen. You're not sitting there calm as a cucumber. We know something's up if you've ever been around anybody with a fracture. And a tumor acts a little bit different as well. We'll touch on that later. MRI is going to show the soft tissues. So certainly a rotator cuff, tears and ligaments, capsules, labrums, all that stuff. How many of you guys have heard of people that maybe have tear in the labrum and have opted not to have surgery? Did you think that was even a possibility? Or tear in the rotator cuff and survive pain-free, fully functional, and not have surgery? Okay, so let's talk about the pros and cons of MRI and x-rays. So they did a study, and out of 100 people that had no pain in their shoulder, and these are guys 60 years old, we were looking for this MRI and x-ray, we were looking for things like spurs, rotator cuff tears, impingement, disregard my handwriting, osteoarthritis. Let's start with that. Of 100 people, let's pretend there's 100 people in this room and none of you guys have shoulder pain and you're all 60 years or older. What percentage of people had positive x-ray and MRI for these things?
Probably a lot.
Probably a lot, so I want a percentage. 60, how many? 80. Okay, it is 80%.
Yeah.
And I'm gonna take this back, I apologize, I didn't look at my stats. It was 50-year-old people. 80% of 50-year-old people that have no shoulder
They were
pain.
asymptomatic, so they didn't.
Asymptomatic, 80% of them. Okay, so now let's take it to the 60-year-olds. What percent of 60-year-olds are gonna have the positive findings? 90. Now, what if we take it up to the 80-year-olds?
Poor babies.
Poor babies, that's 99%. Pain-free though. Tell me about, how are 80% of people with positive findings pain-free? What's the answer?
Muscle.
What else? It's because all of those other parts that we were talking about
Are
were all
functioning.
working well together, and they were not creating, many of these things that you guys are seeing are normal age-related changes over time. They are not painful until you get the narrowing of the tunnel, the impingement, the bursitis, the tendonitis, that chronic repeated trauma that causes those small tears. Those are your warning signs. So, how many of you guys have had injections so far to help with that? Okay, that didn't look like a good response, so.
They hurt.
You've had lots of injections, but you keep going back, so they must help.
Prolonging the inevitable.
Okay, thank you for sharing that. I would agree with you. If the only thing you're doing is an injection, you might actually be contributing to the inevitable. So I'm gonna touch back on that. Who else wants to talk about injections just for a moment? And we're talking about steroid injections where they get in and it's a mass dose of an anti-inflammatory or even a pain reliever. Look, I am not opposed to injections, but I think they have their place. There are actually times when I beg my orthopedic friends, could you please give this guy an injection because he is not tolerating anything I am doing, okay, because it's so far gone. What happens, all this impingement, all this wear and tear, all this change over time, we talked about inflammation like bursitis, tendonitis, your warning signs, right? There's a bursa, a subacromial bursa, that is a kind of a cushion or a pad. It's a spacer, a filler that lies underneath that bony prominence, and it's there to help glide and protect that tendon. Well, just the same way the tendon gets pinched, the bursa gets pinched. And you want to see an angry person pinch off a bursa anywhere in your body. They occur everywhere. You got bursa here, bursa there. And they're there dormant, quiet, and non-problematic until you pinch on them. Or you know, they get angry and they're gonna tell you about it. But it's your sign. Like you said, ice. Ice might calm down that inflammation, but it's temporary because something is causing the inflammation. You can calm it down, but until you get to the cause, it keeps coming back. To the point of injections. The first injection, great. A lot of orthopedic friends say, I sent them to PT. I told them to go, but they won't go because the injection helped. But they keep coming back, and I can only give them 2. Can you please have a talk with them? So you're only supposed to have so many injections because it does wear down the tendon and the articular cartilage over time. And it could actually contribute to that tear happening a little sooner. Well, the right type of exercises and the right type of manual therapy and the right type of pain relieving modalities do what? Help with blood flow. Blood flow sweeps out some of that inflammatory junk and it makes you feel better. And then we open up space and we help you to stop impinging. Those things happening together will reduce your pain and improve your mobility. All right, off my soapbox for that. Time for us to wake up a little bit, and so I'd like to have everybody do a little bit of movement and just help me out here because I want to offer to do a little bit of hands-on treatment with somebody that might be an appropriate match for this technique. So would you guys mind just participating with me here for a minute, just from your seated spots there? Here's what I'd like to see. Everybody, left arm, go ahead and just raise it up there. Kind of take a look at that. Good. All right, and down. Right arm. Okay. All right, good, and down. And bear with me, I'm not trying to make you a patient, I promise. Go ahead and turn, look over that left shoulder. Good, and then back. And then over your right shoulder. All right, good. So I'm kind of trying to see, I've got a mobilization, just something kind of gentle, that a muscle energy technique, just to kind of demonstrate for you guys a hands-on treatment. And with that information, I think I'll be able to get what I need. Dennis,
Yes.
thank you for volunteering. Would you come up here?
No.
And do you mind?
Yes.
I promise I won't hurt, well, I will try not to hurt you.
That took a little effort to do that now, okay?
I know. shoulders, but is one worse than the other as far as movement or?
For my whole life I did a lot of hard work like everybody, so
Alright,
I guess it's,
come stand up here next to me.
but everything I can do, I can do, but it's
You
not
can
pain
do
free.
it. Yeah, I hear you. Alright, so we're gonna show the group now. Left arm, raise it up as far as you can go. Alright, good. So I can see where it starts to get
But
stiff.
sometimes I need my right hand to move my left hand.
I do too.
I gotcha. And that, you push that inflammation too far and your muscles are not gonna work. Pain is actually an inhibitor of your muscles. All right, right arm. The right arm looks a little bit more limited in mobility to me. Would you guys agree? Do you see him struggling at the end?
But
Okay.
it's painful here now.
Okay, so if you had to give it a pain number, what would you say? How bad is it up at that?
Not a 10, but maybe a 6.
6. 0 is none, 10's extreme shaking. Okay, you got it
Okay.
down. Thank you. Look over your left shoulder. Good. And over your right shoulder. All right. That was nice and quick. I don't know. I saw a difference the first time you did it. Does it feel different? Do you guys see a difference left to right? Anybody? Not hard to see?
I
Okay.
don't have any problem with that.
No problem. It feels like it moves easily both sides.
Here and here.
All right, let's see what we can do.
Can't sleep, you can't feel it.
Have a seat. I'm gonna grab some gloves just to keep us all safe. All right, y'all pray for me that this works. I just
Oh, we're
learned
not
this
doing that.
on YouTube last night, so.
No, we're not doing that.
Oh, no, no, no. You character. All right. So here's what I want you to do. I'm gonna just kind of press on here for a moment. Any tenderness or anything through there? Not too bad.
No, I mean, I'm aware of what you're doing.
Good. All right. I'm gonna hold a little pressure here. What I want you to do is I'm gonna push against your head, but resist me. Okay? Push and a nice breath in and out. Good. You can let off your pressure from your head. Good. I'm gonna have you tilt over just a little bit. Let me do that again. Should be pain-free. Push into my hand. A nice breath in and out. Good. And release your head. We're gonna take up a little more slack over to the right. Good. Press against my hand. Nice breath in and out. Good. Get a little more slack over the head into the right. You okay there?
Huh?
Push into my hand. Nice breath in and out. Good. All right. That wasn't too bad, huh?
No, we just feel.
Little hands-on treatment. I'm going to tell you at the end, but come up here. He's not totally limited, so we'll just kind of see. Right side was the bad side. I want you to lift it up for me. How's that feel? Does it go any further? Does it feel any different?
Might feel better.
I see it going
I don't know
higher.
how long it
It's a
was.
little higher. Okay, good. And relax. So if you started off at a 6, what is it now?
I didn't feel much pain.
Wow, okay. Go
I mean,
ahead and
If it was small amount.
turn over to your right shoulder, like over. Does that feel any different?
No, it feels good.
Awesome. Now, did I pay you to come up here? Thank you very much.
No, you didn't.
Thank you. So you asked me, what did I do? I did a first rib mobilization, okay? So your first rib, here's your collarbone, and we can all feel this. You've got, practice this for me. You can reach back here and you feel that big muscle mass back there.
Mm-hmm.
Come just in front of that muscle mass and a little forward in between the collarbone and that muscle mass, closer kind of to your neck, and you fall on something that feels a little tender and it feels a little hard. That's your first rib. Sometimes just the stress through the day, there are a number of muscles that attach on that first rib, and it gets elevated. When it gets elevated, it starts taking up some of that space. All I did for you was one quick piece of a space-relieving technique. Now I'd want to see, why is that rib elevating? Is it something to do with your work position, your sleep position? There's so much more for me to have to evaluate. I mean, I have not done a full evaluation. Truly, I was just looking to help make a small change, just to kind of serve it as an example of what's the difference for hands-on treatment. If you're at a place where some of you had mentioned having gone to PT before or having tried other treatment methods, if you're not getting somebody who's hands-on looking to see how are all of those components that affect shoulder motion and mobility going together, and look guys, this is not a quick fix. To your point, hey, it's a little better, but how long is small technique. What did we do? 3 or 5 reps? And so we got about a 3 or 5 rep result. Does that make sense? And I'm not expecting miracles, even though I called it a 5-minute miracle. But imagine piecing a number of those things on top of each other as we problem solve the number of causes that are underlying your problem, and then we're teaching you what to do to go home to reinforce what we just accomplished today. Okay? Good. Thank you for helping. All right. So, I'm going to move kind of quickly. We have about 15 minutes. Who am I? I'm Michelle Sierra. You guys got to meet me on the video. My husband and I own Dynamic Physical Therapy. We started Dynamic Physical Therapy back in 2000, so I guess we're 20 years old as a business now. Started on the West Bank, went to school at LSU Medical Center in New Orleans on Gravier Street. And I actually sit on their advisory board now, which I'm really excited for. My primary practice is actually in pelvic health, so it's funny that you decided to use that joke. Because we do treat a lot of pelvic floor dysfunction here. Won't get into that, share that for another day. But how did I become an expert in shoulders? Because I had a really crappy surgeon in my area. I won't mention any names. But then he had a really good partner in the other practice. And a number of post-op shoulder patients would come my way, and they would, after surgery, they're like this, and he would keep them immobilized for longer, trying to protect them. And back as a new grad for me in 1995, we were not as manual therapy based. You know, I'm willing to admit that. We were not as hands-on. Those treatments have evolved greatly over 25 years, and some of these whippersnappers that get out of school can come in and teach me a few things, but we learn from each other, right? So my last drawing that I want to show you guys here is what can you expect? How does, PT in a nutshell? So back in the day, this is what PT looked like. You had a number of people here in this 25% range that were super happy with the results they got in PT. Okay, got better, no problems, hands down, life's good. You had a number of people here that were like, you know what, I'm not any better, but I'm not any worse. And we didn't know what to do with that 25%. So we'd send them back to their doctor and they'd have injections or they'd go on to surgical procedures. And then there was 50% here that were like, it helps, but it's just not enough. Like it didn't really solve it. It gave me out pain, but it never solved the problem. This dates back to a study that is 20 years old. Remember, I started practicing 25 years ago, so sadly, I was in that number. But what made me the expert was those crappy surgeries. Do you know why? Because I had to get them better, which meant I had to learn where to push and how to push. I think I was doing clavicle mobs and rib mobs and mobbing everything I could to try to get their motion back so they could have a successful result after some of their surgeries. And I look back in hindsight and I think that was part of it. So that's the bad news. What's the good news? Fast forward 20 years later, the study looks like this now. 10% and 90%. Do you know what the 90% is? People that are happy and satisfied and felt like their problem was addressed in physical therapy and they got back to normal and living normal life. Why? Because a lot of these hands-on techniques. The exercises are critical, but they need to supplement what you're doing with your hands-on technique and making space and making sure that all the parts are moving properly. As much as this is what the study shows 20 years later today, and this is an awesome thing, I'm ashamed to say that I still get shoulder patients that have gone to other places or have done other methods or done things, and they didn't fall in this 90%, and not all PT is the same.
That's so true.
And it does require hands-on, one-on-one care. If you've been somewhere and they're not putting their hands on you and helping you to move and getting things moving, you can exercise till the cows come home, right? And you can't quite get it. Or the same thing, we had a speech therapist at our last workshop, and she works in a pediatric group where she has a PT that works with her, and she was talking about her shoulder pain. Didn't really undergo a full eval. It was just like a handshake friend thing. Oh, here, try these. Here, try these. My best friend lives in California. She's like, Michelle, my shoulder hurts. I'm like, girl, don't ask me to email you some exercises. It is not that simple. Find a PT. I'll help you find a PT. You need to go, hands-on, see what's going on. So that makes me proud, aside from the fact that we're not all doing it the same. Scott's gone on some super awesome courses here recently with rotator cuff, and he's kind of the mentor and the trainer, so that even if there's a newer therapist joining our team, we're co-treating, we're working hands-on, we're making sure everybody goes through the same continuing education, so we're all mastering those hands-on techniques together. All right, where are we on our number 3? Back to normal. What are the first steps? Oh gosh. So if you didn't think I talked too much, maybe I write too much. Oh, poor little Vanna White. All right. So, don't know where I'm going next. How many of you guys, I did not hear the story in here, of constant shoulder pain that does not change no matter what I do? Is there anybody in here that has that story?
My mother does, but she's 84 years old.
I'm sorry?
My mother does, she's 84 years old, but she tore her rotator cuff like 20 years ago and wouldn't have the surgery because she's claustrophobic and she wouldn't have them tie her arm to her.
And
So
so
I heard
her-
the other day that they have surgeries now where they just have like the 3 cuts, and she goes, okay, I might do that. And then I saw this, I was like, well, wait. So,
Okay, and so I think you bring a good point. Somebody had posted on one of the Facebook feeds, well, what if it's a full thickness tear? I can assure you guys all in this room who I saw move, I did not see any full thickness tears. Do you know why? I can ask any of the PT, how does a full thickness tear look when I ask you to raise your arm?
my mom can do like this, that's about as high as she can get.
It looks like this. It looks like a penguin. And I mean, I don't mean to make fun, but the supraspinatus's job is to engage that to come down, and then for the deltoids and whatnot to take over. If you cannot get the initiation, you won't get past 30 degrees because there's nothing there to pull that ball down. Now your mom might have some frozen shoulder and capsular changes and things like that honestly she might do better having PT first. And so sometimes we do see surgical cases, our orthopedic surgeons are like, yes, you need surgery, but you've let this go for so long, it's a full thickness tear, I need your range of motion restored before I do your surgery, because if you're already stoved up in there and everything's tight after, when we try to do your rehab, you're shot. That's not gonna go very well. I did have some cases with a full thickness tear that were not surgical candidates because of age, medical history, too many other things. What do they do with those guys? They send them to us to help get all those other parts moving well so that A, they don't hurt as bad, and we can maximize the movement and give them movement strategies. So we see it all. We see it from A to Z, and our job is just to help. How do we restore and maximize what you guys have left? How do we keep you from having repetitive injections? I'm not saying the injections are bad, but you gotta do the cleanup work of what was the underlying cause to the inflammation. And I'm not saying that MRIs are bad. There are times when I got this going on, and maybe it's just because of pain. Maybe it's so inflamed, I'll do my certain thing. But when we see red flags, constant pain, unchanged by anything. My pain's the same whether I'm sleeping. My pain is the same whether my arm is up. My pain is the same whether I'm lifting a 20-pound dumbbell. It does not change ever. Movement, activity, I am sending you straight to your doctor to do some special testing to rule out red flags. Kind of like that tumor we talked about earlier. Not that that's your mom's case, because she has a specific case, a cause, an underlying cause. But I have seen that before in a hip patient that I tried really hard for about 2 weeks, and the poor guy's pain got worse with everything I did. I'm not gonna keep doing it. I'm gonna go get help. Send him to his doctor to say, hey, have I missed something? Do you need to do some imaging? Does he need an injection? We are part of the medical team. We work very closely with primary care, orthopedic, neurology, rheumatology, and we know these guys in our community. And so we help them by getting them the right people when surgery or injections are the next step. But they refer back to us when we need to help them either pre-op or post-op. Or any good surgeon will try to do PT first, inevitably, to try and prevent surgery in cases where it's not needed. Or people that are having a tough time making that decision. Well, like the lady in the back, I would like to try not to have surgery. Good. Let's see if we can restore all those joint mobility and muscle anatomy, re-educate those muscles, retrain them on what they're gonna do, and you may be able to do fine. The other thing that made me an expert in shoulders is my poor husband, who has a labral tear, dislocated his shoulder bench pressing, still wants to do overhead press and everything else under the sun. And so I had to be the one to help kind of retrain, and had we not trained his serratus, which was his main stabilizer that was out attached to the, he couldn't even find it. He didn't know how to engage it. And this is a muscular man from the gym that's doing all this high level stuff. Once we got that serratus engaged and he knew how to get that ball to pull down and not impinge, problem solved. But it takes work. So if your pain is reproducible is the word, reproducible. The sleeping, the exercise, the lifting, every time I do this, it's reproducible. You guys know what it is that reproduces your pain. Then it is reducible, because there's a cause. We have to figure out what's out. What are the pieces that are out? Start fixing them one by one, and you will see that pain starting to reduce, kind of like that one piece we did with you, Dennis. All right, so in the past 30 days, the worst pain I've had was, write that down, and I have the pain when, circle whatever you've got on there, and I promised you guys in the video that I was going to give you an answer to sleeping. What is the wrong sleeping position? What is the right sleeping position? Because at least half of you,
I'm sorry, Kitty.
not me, come on,
I want to sleep with
Train
my
you.
arm over my head.
Yeah, how many of you guys said pain with sleeping? At least half, probably 75% of this room. And so you just can't find a comfortable position. One of our patients, you know what his goal was on initial evaluation? He was not here because of pain working out or pain working or pain lifting. He was like, I'm here because my wife made me come here. She said therapy could help, and that I have to start sleeping in the bed again because I've been for a year on the recliner.
Oh, no.
I'm here to save my marriage. And I was like, well, all right. And so when you're upright and you're not laying on one side or the other, or even on your back, or God forbid, arm over, your spouse or something like that, post-op patients are always in a recliner. And sometimes our goal in the first, couple of weeks post-op is let's get you sleeping in the bed again. So how many of you guys sleep with your arm up because you're on your side or you're on your stomach?
I usually
Job.
I don't know how to stop it. I knew you were gonna say.
Remember the space that we were talking about in that tunnel?
Yes.
When you're sleeping like this or you're sleeping like this, you have now impinged that space. What we need is an open position. So,
That's exactly what's causing.
take a pillow. I want you guys to try this because I would like for you to sleep better and have your own little 5-minute miracle of sleep tonight. So, take a regular size pillow. This is a baby pillow, but it's all we had for demonstration. Just a regular size pillow. The mid position of it, and I go over this with every new shoulder patient that walks in my door. We spend an hour measuring it one-on-one. What's your neck doing? What's your shoulders doing? What's your back doing? Okay, we check all of our boxes and make our problem list of what we're gonna do first. I wanna send them home with something helpful. So I talk to them about ice in pain relieving measures and help reduce inflammation, 10 minutes at a time, as often as needed for pain, preferably with not directly on your skin. And I say, here's how I want you to sleep tonight. Take your pillow, midway, stick it in your armpit. And if you've only got a right painful side, you can sleep on your left side. That works. Or you can sleep on your back. And if you're on your back, you want to make sure this part of the pillow has the back of your arm supported because you have a bicep tendon on the front. I bet a lot of you guys have bicipital tendinitis as well because the bicep is being abused trying to help stabilize the shoulder that's all wacky because all your other muscles are up. Okay? So, after surgery, it's most important for blood flow, for healing, to get that inflammatory crud out. Blood flow for healing. You heal mostly at night. Your cells are going under cellular repair. If you're in a closed position where that tunnel is squished on the bursa and the tendon that are all inflamed, they have no opportunity for good healing with fresh oxygen and nutrients, really on a cellular level. So, armpit, back of your arm supported if you're on your back. Take that with you for driving. If you're driving and you can have your arm just that 30 degrees away from your side, resting on the console, it's actually good for the blood flow in your shoulder. Or sitting in the recliner watching TV tonight. Put a pillow under there. Just see if it helps. I'm just giving you guys opportunity to start getting better blood
And
flow
if you
there.
want to sleep on your stomach?
Come see me. You'll make a great patient.
Oh,
It's good for
yeah.
business. All right. Because it's also bad for your neck, and that may be contributing too.
Yeah.
So, The number one biggest mistake shoulder pain sufferers make is who said it? Who said it? A+ star student, thank you very much. They ignore it. Now, I heard years. How long? You guys have been ignoring it really good for a really long time. Did you get the gist of what happens when you ignore it? It goes from those little warning signs of, hey, bursitis, might want to take care of that, something's wrong. Like, no, I got this, I just won't bench press today. And then it feels better until you go bench press again. There's something underlying that. The swimming, all that. So, number 5, the 3 things you can do about shoulder pain right now. Here are your options. A, well, you could continue to ignore it. Okay, by show of hands, who's gonna choose that option? Because I want your name.
I did for a while.
You did for a while. And how'd that work out?
I had surgery 13 weeks ago.
Well, all right. So you need therapy now, or are you in therapy?
I'm in therapy, yeah.
Good, all right. So you can ignore it. I don't advise ignoring it. You will only get away with that short term. And it creates for bigger tears, bigger problems, and things that surgery may be your only option when you ignore it too long. So, B, what else can you do? I heard you guys say something, well, I could use the other arm. Or I could just turn my whole body, like I could alter it, I could alter how I use it or how I move it, but you're only contributing to the muscle imbalances and the loss of motion in the frozen shoulder. And what are other ways to alter it? We talked about injections or medication. How about I just take the pain pills? How about I take the anti-inflammatory? It will get rid of it, again, short term, but it's not fixing the underlying cause. And until you get to the underlying cause, it's not going away. All right. Or C, you can handle it. And that's why we're here, to give you some knowledge and information so that you can decide to start taking care of it. Number 6, the top 3 common causes of shoulder pain. There's 3, and I've heard these answers already. Top 3 causes. Anybody want to take a guess?
Sleep.
Sleep. Okay, well, causes of shoulder pain. Impingement that could happen by sleep. Impingement that could happen, so my friend there in the green shirt, when you do this, it's impinging. There is something, that ball is not dropping down. There is something getting in the way. You're not clearing that space, and it's just enough when you get midway. There's a thing called a painful arc, and it's usually from about this here to here. Now once you get past it, like if you used your arm to get past it, well, it may not hurt up here. And then you go back down and, oh, there it is. Classic sign of impingement. It's starting off as a warning sign. Don't ignore it, because it'll turn into other things, right? Your neck, we talked about that. And the last one's poor posture. Kai almost stole my thunder over there, and this guy too, talking about it. So just for example, again, we'll use your good shoulder. Everybody sit up nice and tall. The other thing I cover on initial evals, I talk about ice, I talk about sleeping position, and I talk about postural correction. Those are the 3 things, not the exercises, but those are 3 things I give to all my shoulder evals. Chest up, tips of your shoulder blades kind of back in your back pocket. You guys are great. All right, on your non-painful side, if you have one, raise your arm up and see how far does it go and how does that feel. Good. All right, bring it down. This is the one time in a PT clinic that you're allowed to have bad posture. It's the only time, or else we got the posture police. Okay? So, everybody slump down, as if you've been working at the desk for 3 hours and you're just ready to get out of work, right? If you're Scott doing his paperwork for 3 hours. Now, that same arm in that position, how far does it go and how does that feel? Do you see the difference of just postural correction? All you're doing with postural correction, you're not creating strength, you're just opening the space. And it'll reduce how often it gets impinged. And impingement, I teach my, it's kind of like picking a scab. You wouldn't keep picking a scab and watching it bleed, but you can't see what's happening on the inside of your shoulder. You keep digging into that tendon and that bursa, and it's just cascading inflammation. All right, so what does successful, non-invasive, natural treatment look like? Hands-on PT. We have really, I hope, driven that point home. We have to get things moving. So to move is your next blank, the shoulder and the to retrain. So it's strengthening exercises as your first blank to retrain. As I said before, this is not just go to the gym, just go do some YouTube rotational rotator cuff things. Although, hey, something's better than nothing if it works for you. I'm not opposed, but you need to know what are the right things to do based on your muscle imbalances that you're dealing with right now as you let things go or things are problematic. So it's just individualized to what your underlying causes are. C is pain and inflammation, relieving modalities, and those are some of the things we do here. Ice is one you can do at home. We have a number of other things we do here to reduce pain and inflammation. All right, so you guys, we've finished things up and you have another form. Everybody's got their blanks filled out? If not, come see me at the end. I'm happy to answer any questions so you can have your study guide and go home. You guys also got a sheet here. It's a feedback sheet and a checkout sheet. I would really appreciate everybody taking a few minutes to fill this out and give me any feedback on ways that we can make this better in the future. I'd like to get y'all off to dinner. Now the last thing is, I said you guys have 3 choices of what you can do for your shoulder pain, and I don't think we had any volunteers to ignore it. Alter it, we've talked about that, or handle it and deal with it. And honestly, with the stories I've heard, I think we could help a lot of you guys move in the right direction towards getting some resolve and relief. So we have 342 visits on the next week, and we are doing our due diligence to stay within our COVID guidelines. We've got private treatment rooms on this side and that side, and you see the curtain space, and this is a little unique arrangement of our space here, but we have tables between those curtains. We are following all of the CDC and Department of Health and Hospital regulations, spacing, distancing, hand washing, sanitizing, all that stuff. But I did ask Sherry and Candace, they are our scheduling team, they're the masters of schedules, to open a few spots next week, because I know through Sherry's conversations with some of you guys, some of this is pretty intense, and some of you guys are looking for help straight away. And some of you may even gone through free exams already, but wanted just a little bit more information to know what successful treatment is like. So I'm gonna ask, maybe, do you want 6 at a time? The first 6? Anybody that has 5 out of 10 or higher pain, I would like to offer you guys the first few spots, because they're gonna fill quickly, and then anybody that has maybe a little lower pain level or feels like they're doing a little better, we could maybe find room for you in the next week or something like that. Either, I'm in pelvic health now, so it probably won't be with me, but Scott or any of the therapists here that are our shoulder experts would be happy to help you guys with any of that. The rest of you can sit back and hang back for question and answer time, and then we'll look to wrap this up in the next 5 minutes or so. Any questions or anything before the first couple of people want to take a walk with Sherry? We can mingle, we can, put our masks on, keep our distance, have my staff come over and answer any of your specific questions. Thank you for joining us. I hope it was what you hoped to get out of this, and I really hope to see every shoulder in this room. While I work over there, I make my ways around here, and it'll be nice to, I have some previous workshop participants, and it's nice to check back in on them and see that they're making the progress that they were hoping for. So, thank you for coming out to join us.
Thank you.
You guys want to walk out with Sherry, and then if anybody has their checkout sheet and they can't stay because I've taken 5 extra minutes, please give them to Sherry and Candace, and they will do their best to get in touch with you guys tomorrow if you need to rush home to kids or dinner or something like that.